surprising because there was actually a building and a big idea of Dr. Kung. But it was obvious that this is a very nice blueprint, but I never expected that it'd be as busy as it is today. So what we see today is extraordinary. I think what you did for the area and what you did for stroke treatment in Asia is extraordinary. And I'm very happy to be here today to talk about this endovascular stroke treatment in complex cases. But I'm mainly going to focus on tips and tricks. So I'm not going to talk about single cases that I've seen during my career, but rather about things that you might apply, techniques that you might apply yourself one day. As I said, I've been here before. I have been here for the first Asian Stroke Summer School with the animal model that you will see tomorrow as well. It has been a very interesting time. We went out with a speedboat that time. This is not Dr. Kung, as you can see. It's me wearing his lead, and the only person who is in charge of all this is him. I'm going to show a couple of cases, what we experience. I come from a very busy stroke center in Switzerland, so we have around 400 intra-arterial cases a year. Just because we do it the way, it doesn't necessarily mean it's the only way. It's just something what we came across and might be interesting for you to apply some of these techniques yourself. I'm going to go through a straightforward case or straightforward cases, go for the use of balloon guide catheters, how to reverse the flow, and if we have time, go for anchoring techniques as well, but probably have to skip that. Just straightforward, if you come here and you are going for a hands-on course, what is the most easy way to do this? And I just brought you one case of a young chap. You can see the oh, I'm sorry. We're going to start in a few seconds again.
Now I would like to invite Professor and the chairman to come to the stage for take a seat. And now I would like to invite Dr. Professor Nguyễn and Associate Professor Mai Duy Tôn and Associate Professor Lê Văn Trường come to the stage and take a chair in the table on the stage.
Vâng, và chúng tôi xin được mời giáo sư Nguyễn Huy Thắng, Phó giáo sư Mai Duy Tôn, Phó giáo sư Lê Văn Trường lên bàn chủ tọa.
We're going to continue at this point. I just want to say there is an easy way of treating stroke, and I just want to show you a simple case. You will probably go through those cases with your hands on one day. Someone is clicking my slides. Good. So this is a young chap, and he has a MCA occlusion on the right-hand side. We just saw the injection on the left-hand side. We see injection on the posterior circulation. You already see some collaterals going. The patient is awake. We used to do some of these interventions with patients without GA. We changed to GA now, and you see the stump of the MCA. So straightforward case, straight vessels, lots of pile collaterals. So that's a good case to start with. And you see that the diagnostic catheter is changed to a larger catheter, taking a long wire into the ECA territory, then advancing the balloon guide catheter. For most of the cases, we still use balloon guide catheters, and one of the targets for today's meeting is also to explain you what you can use the balloon guide catheter for, not only blocking the flow, but also reversing the flow. So the balloon guide catheter goes to the ICA, and from there we have large access, 8 French, 9 French access to the ICA. Balloon guide catheter in place, not inflated, so you see the nice stump there, M1 occlusion, and then you know the procedure. You take a micro wire, micro catheter, you try to work your way up to the clot surface is there, and everything beyond this is obviously occluded. Sometimes it's easy to pass with a J-shaped wire, which is less traumatic, as in this case it was not that easy, so sometimes you have to take it back and then advance the wire and then advance the mic catheter. Once the catheter is beyond the clot, for any kind of stent retriever thrombectomy, that's very, very helpful, because then you can access the territory that has no perfusion anymore. So you're distally to the clot, so you're in the affected brain area. Now the catheter is there, the balloon guide catheter is down there, and you're loading your stent retriever. We use solitaire, but there are a couple of different ones that you can use. So you load your mic within your mic catheter, your stent retriever. You will see the markers in a second. So once you have this setting, you have an access from the groin to the affected brain area. See the markers passing, the distal marker, the proximal marker, and this is the stent marker. So once we pull back the microcatheter, the stent will open and create some temporal bypass by compressing the thrombus. So this is what you see right now. We're going to pull back the microcatheter, and then this marker opens and creates some temporal channel, because most of the strokes are from emboli. This is not the solution, so we can't leave it like that, but we're going to do the thrombectomy. For this, the balloon guide catheter helps us to prevent embolic events, so we're going to inflate the balloon. Now there is no antegrade flow, and then while we pull back the stent, we're going to reverse the flow and then aspirate on the guide catheter. So for the first time in the life of the patient, we're going to have the flush going downwards, pull the stent retriever out. You can see it here. The patient is complaining, it's sometimes a little bit painful. And then we deflate the balloon and see if we have caught the thrombus and have recanalized. That is not a complex case, that's the most straightforward case, but this is something that you will do probably every day in your now it's recanalized. In your practice, at the same time, this might also be something that you will practice here during the endovascular course. Sometimes a single stent retriever does not help you. So this is a younger patient with a basilar tip occlusion. So it's a bifurcation thrombus, and after a couple of attempts, it's still occluded. Basilar tip, the patient will most likely die, so you have to do something in there. Sometimes it's helpful to use more than one stent retriever. So you have one in one side, one on the other side. So 2 stent retrievers. It's important that you take one mic catheter, place this one, another mic catheter, place this one, so not entangled. And with that, if you then pull, the thrombus is compressed, you can pull up a microcatheter or aspiration catheter, and then you can retrieve the clot in bifurcations. It's used more and more in the carotid T, in the basilar tip. Unfortunately, it's quite cost intensive because you have to use 2 catheters. This is a very nice run that you can do with some of the new angios. So we have icono angios, and you can do those runs pretty nicely, and then you can recanalize. Balloon occlusion catheters have, first of all, it's a protective device, but I would like to show you that you can use it for other things in complex cases as well. So basically, it's to prevent emboli from going into other territories. So it's a protective device because you reverse the flow. You can't reverse the flow by a normal guide catheter. so the diameter does not allow this, but if you take a balloon guide catheter, you can block the flow and you can reverse the flow. You can do this with a pump, or you can do this with aspiration syringes, as we do, which is a bit cheaper and does the same. Once we start to pull, we open up the aspiration, and you will see that immediately the contrast goes down. So the aspiration force in this setting is very, very strong, and the recausation effect is very high if you get to this position. However, very often you can't place it because you have elongated vessels. So obviously you run into those patients, and you can't place your balloon guide catheter somewhere up here. You have to stay down there. If you do so, unfortunately, the aspiration force is almost zero, because what is happening is you have an anchoring effect. The stent retriever is up there, you start to pull, and now the balloon actually, you can see that with the red line, the balloon moves up, the ICA is shut down, and then you aspirate, and there's almost no aspiration force. So if you have to stay down there, the balloon guide catheter doesn't help you very much. So in those cases, it's much more reasonable to not take a normal catheter and then shift everything up there by using aspiration catheter in addition. So balloon, nice if you have straight vessels, not very helpful if you have elongated vessels. And the same accounts for carotid double tandem occlusion. So if you have an ICA occlusion by a stenosis, you can't use a balloon. However, for dissections, it's sometimes helpful, because for dissections, you want to have antegrade blockage, and for the distal embolus, the aspiration catheter. And this leads me to one more trick I would like to show, which is reversing do reverse angiograms. And I will show you what this is about. So we have a patient, and the patient used to have or has an ICA occlusion. You went up, you have a balloon proximally to the ICA dissection. You went up with your aspiration catheter up to the thrombus. You have recanalized the intracranial vessels, so that's very, very nice. The problem is how to treat the ICA dissection now and how to illustrate it. Because if you want to inject contrast from down here, you run into the risk that you embolize more thrombus up again. So you might re-occlude your ICA again. How do you solve that? One possibility is you reverse the flow again. So if you inflate your balloon and you aspirate down here and you inject contrast up here, it actually does not go upwards, it goes downwards. So you can inject contrast, it goes down to your balloon, you can illustrate this certain segment without the risk of having emboli. And this looks like this. So you have your microcatheter up there, your balloon down there, and you inject the contrast, and instead of going up to the brain, it goes down. So now you can illustrate the dissection, you can illustrate how it looks like without the risk of having embolic events. And I think that's a very nice way of using balloons by having retrograde angiograms. So you don't take the risk of embolizing up again, you can illustrate something just by reversing the flow and showing the segment between the tip of your catheter and the tip of your balloon guide catheter. And probably for the sake of time, the last thing you can do is in dissections as well, because ICA dissections, especially in younger patients with an intracranial occlusion, is a big problem. If you can't pass the dissection, you can't treat the stroke. So you have to pass it somehow. So this is a patient who is 50 years, he's not 5 years, 50 years old, high NIHSS, and has ICA dissection and carotid T occlusion. So you see the ICA dissection on the right-hand side. You see that the carotid T is occluded, but there's only very few infarct volume now. So that's a good setting, but you have to recanalize. Otherwise, the patient is likely to die. The problem is how to pass the dissection, and this can be very challenging. Why is this the case? If you have a dissection, there is the intima, and the intima is like, it's pushed up all the time. So it's like you have antegrade flow, and this antegrade flow is like sailing, the intima is like sailing in the wind. So it's always occluding because the intima is pushed up. And this is very difficult to pass. Now, if you take a balloon guide catheter, you might have the chance to reverse the flow, which means it's not sailing in the wind anymore, and you might be able to get the intima back into place so you can pass. And to push this to the limit, this is something what I regularly do. I inflate the balloon, I aspirate, and while aspirating, I'm passing. And if this is not possible, you could even take it a step further. So you have your balloon guide catheter, you have your dissection, and now you take a second catheter. So you want to, while you're aspirating, you're reversing the flow. Now you take a second catheter, and you inject contrast, and it goes up. If you have an ACOM, it goes up, and then goes down again. So you can not only get the intima back into place, but also find a rope map pathway to pass your dissection. And this is how it looks like in this particular case. So you have the stump of the ICA. There's no antegrade flow anymore. It's just the stump. I tried to pass with inflating the balloon. I tried to pass with a microcatheter. This is the contralateral injection. You see there is an ACOM, but nothing goes down. That's why the patient has few. So now this is the stump. No antegrade flow in the ICA because the intima is blocking the flow. Even if we inject a little bit higher, we see that there is the hematoma, but no antegrade flow because the intima is flying in the wind. It's always pushed up by the antegrade flow. So now I'm inflating the balloon, aspirating down here, and now you suddenly see that it comes down. So we're pushing the intima back to the wall, and we can use this as a rope map. So now suddenly you have a rope map. It's difficult to spot there. You have your microcatheter, you know where to go, and although there was no antegrade flow before, under aspiration and by occlusion, there is a chance to find a way because now you have a road map. And you can follow this road map and find your way to the dissection. There you go. And then you suddenly can go up by reversing the flow, getting the intima back, and then recanalize that patient. So recanalized, and then you can treat the dissection later on. But the reversal of flow is the key to get the intima back into place. I'm just going to have one more thing, the anchoring, before I hand over to the next speaker. A stentriever has a high radial force. So you have something in place which is a high radial force and there's a wire attached to it. So once this is in place, you can use it to bring up almost everything. And you can do this for intracranial occlusions to bring up your aspiration catheter, but you could also bring it up earlier in the stage. So if you have very elongated vessels, sometimes we place a stentriever just to get into this location. So sometimes we actually place the stentriever already in the ICA. We use the stentriever to pull up our guide catheter and then go from there. So I'm going to stop at this point. What I want to show is the normal technique. Sometimes you have to use two stentrievers to get bifurcation thrombus. The balloon guide catheter is a helpful protection device. Sometimes you can easily use it to reverse the flow to do angiograms, and especially to get the intima back in dissections. And the anchoring technique is something that I'm going to touch anyway with the second talk later on. So I'm not going to go into too much details. And I would like to thank you for your attention.